what they're symbolizing is the numbers. CO2 output for a person should be normally 35 to 45. I know you can't really see those numbers on there, but in the right above those blocks, you see a number 38. That's in the range, 35 to 45. Now, let's say you get to the hospital or you turn this thing over and they say, hey, man, the airway's not in the right place. Well, if you got them on a capnography device like this, always as the paramedic advanced EMTs, when you start, you want to record this. You hit the record button, on some of those monitors, you can hit the snapshot button and it will capture that capnography. And I've used that to defend my medics and stuff in the past, because they'd get to the hospital and say, hey man, that tube wasn't in the right place. I said, well, no, y'all must have moved them when you moved them over, because I got the recording up to the time y'all state that the patient arrived on the bed. So that will, it not only saves you in that point, but it also tells you how well you're doing. In cardiac arrest, that number may only be about 20, but the fact that you are getting a reading shows that you are in the right place. If you're watching that and it goes all of a sudden goes down to 0 or flatline, that's when your airway may have become dislodged or something might have happened to it. Now, let's say if you got a reading of around 20 and you can barely notice if you're doing CPR and that capnograph is about 20 and all of a sudden it shoots up to 40 and 45. How does that happen? That can only happen if they got a pulse. So that's one way to monitor if you got what we call ROSC, or return of spontaneous circulation. So that it's a valuable tool, and it is pretty much a must anytime you got a advanced airway in place. If you don't have capnography, then you may not be in the correct place to monitor that. The blood glucometry, simply checking, when do you check somebody's blood sugar? If for the most part, anytime somebody has an altered LOC, that's when we need to check that. Anytime you have somebody's known diabetes, and not always they have to be a known diabetic. Somebody will say, I'm not a diabetic, and they go to checking their sugar. They'll say, well, you don't have to check their sugar. They're not a diabetic. It's still always a good idea to check their sugar, but have an indication to do so. And the reason I say that is that some people will, and I've heard people say that, well, if I start an IV, I check their sugar. Well, what was your indication? Well, I just do that. Well, that's not right. You don't need to check somebody's sugar just because of it, for your own satisfaction or whatever. There needs to be an indication. LOC problems, unexplained actions, or anything like that. If you can tell yourself why you're doing it, that's one thing. But just because you start an IV is not a reason to check that. And that goes for, like, if you work for a service that bills, they may get. I mean, how many of you like getting a charge for something that wasn't needed if you go to the doctor or whatever? Believe me, there's a bunch of them. But in some cases, just for that glucometer check, they may charge $75, $80 for it when it really wasn't needed. And it's just because, well, I started an IV, I check sugar. That's just not good enough. Also, let's talk about getting into the full bodies exams. What you're looking for now is hidden injuries, unidentified causes, significant mechanism of injury. You want to look for issues that may have happened to the patient that wasn't really apparent at first. There again, you don't want to be that person that goes in with, oh, I didn't see this knife in the back, or I didn't see this big hole in the mid femur. You want to be able to expose and find these findings. It may be something as simple as a big abscess on the knee or the back of the leg or something like that, that may cause like a major fever. Somebody has a severe fever, low blood pressure, then you find this big abscess. Well, it could be sepsis and things like that. Now, the secondary exam, if someone has a focus problem that's not life-threatening or anything like that, you may you're able to do a full body exam on scene. But if there's any type of life threats or whatever, this is to be done on the way to the hospital, and then only after uh, the the severe life-threatening injuries have been taken care of. Now, what is a focus assessment? Now, that's usually someone that has, there's not anything else life-threatening goes on, and you get there and they might have something like, man, I'm having pain in my left arm where I fell down the stairs. You're going to focus on that one point right now, as long as there's not a lot of other things going on. So remember, those assessments can be divided up. You got a full body and you got focused. Now, if they're complaining of hand pain, there's really no need to expose the rest of their body if that's the only thing that's going on. And those are like based on your chief complaint. Severe abdominal pain, hurting all the way to the back. You're probably going to have to do a more torso type exam, even looking at the back, maybe even asking about uh, hematuria or things like that could go along with it. So a focused attention, it focuses on the immediate problem. The respiratory system, when the exam of the respiratory system actually begins when you walk in the room or whenever you can hear the patient. You're not supposed to hear patients breathe. That's when they're normal breathing. You shouldn't really hear it. But when you look in and walk at the patient, you want to trauma or medical. Look for signs of obstruction, trauma to the neck or chest. You're going to expose, inspect. Overall symmetry. It's important to note that the patient has, when I note a patient that I examine, patient has symmetrical chest expansion or symmetrical rise and fall. I want to state that just about on everybody I see, because that's something that I see. I can tell it from across the room. Sometimes you might have to expose and get a little bit closer to them. And then respiratory rate, chest rise and fall, and their effort. Are they having to work to breathe? Do I see retractions around the collarbones, around the upper sternal notch? Do I see any indentations or anything there that could be causing this patient to have issues? The pulse rate, skin blood pressure, of course, goes along with that. And when you start to listen to somebody's breath sounds, remember, side to side, up and down. You want to listen at the very top of the apexes, which is right below the collarbones, and again at the very bottom of the lungs, which is actually not too far below. We're right by the xiphoid process across on both sides of that, and then also in the back. We'll show you some pictures of that in just a minute. Now, the also, you may see subcutaneous emphysema or abnormalities of the chest, or breath sounds difficult and different in different areas, and that also needs to be marked, and monitor for any kind of changes in that. Now, subcutaneous emphysema may not be apparent right away. You may look at somebody's neck, and where does this happen at? I've seen it under the arm, I've seen it on the side, I've seen it in the neck, under the chin, and I've actually seen it in severe cases. I've seen case where major trauma patients had subcutaneous emphysema in the scrotum. I remember one particular individual had his scrotum was the size of a basketball because of all of the sub-Q air that leaked out and got in. Needless to say, he had a tension pneumo and ruptured diaphragm, but that's that was pretty obvious. But look at someone's neck. If it looks normal, then you note that initially the patient looked normal. However, 5 minutes from now, you can start to have subcutaneous emphysema and some abnormalities start to develop. Now, how fast should adults breathe? If you look at a lot of paperwork that's handed off to you, transfers, things like that, it seems like they want to automatically write down 20 times a minute, and that's on the higher end of an adult respiratory rate. Most of the time, people should breathe between 12 and 20 times a minute. This is for an adult. So when you're do you have to count for a full minute? No. A lot of times I'll count for 30 seconds, 20 seconds, and that is when I'm getting an exact count. Now, I'm just worried about if it's fast or slow respiratory rate. But once I get into my secondary head to toe and start my vital signs, then that's when I'll get my accurate respiratory rate. and that is one complete cycle, one inspiration, one expiration. Now, when someone's unconscious or altered, you can pretty much count their respiratory rate right away, whether they know what you're doing or not. But if someone is conscious, if you tell them, hey, I'm going to count your respiratory rate, most of the time, I mean, that's just hard to do. If somebody to tell you that, what are you going to do? You're going to control your respirations. So do that while you're checking a pulse or talking to them, or while you're doing some other task. Count the respiratory rate without them realizing that they're aware of it. And when we talk about respiratory rhythm, are they regular or irregular? A lot of times, if someone's having a problem breathing, whether it be from the blood chemistry, the gas makeup inside the system, they may have an irregular pattern, or sometimes neurological injuries, severe head injuries. They can have a Shane-Stokes type of respiration, or metabolic acidosis, DKA, if they're totally unconscious. Sometimes they can have an irregular respiratory rate with that. So note that it is regular or irregular. Now, the quality is how good is what they're doing working. Are they moving air in and out of the lungs like they should? So this listen to breath sounds on both sides of the chest early. That can that's part of breathing and airway if you're checking for a trauma patient. If you have someone with severe chest trauma, you might suspect they got the correct mechanism of injury. The initial breath sound part can be during the survey because that's part of breathing. You're mainly listening right now just pretty much to make sure that it is present and it is equal bilaterally. But in the secondary, you can get a little bit more in detailed on it to see if that's when you want to listen to, like if they got wheezing, rales, rhonchi. If you're able to try to even describe the type of breath sounds that they are. Now, people will sometimes differ on whether or not they say, well, this is rales that I hear, or no, this is rhonchi that I hear. Sometimes they are really confused about that. You need to find a way that will help you discern between those breath sounds. Let's look at the first one, stridor. And that's usually, sometimes you'll hear that with small kids who have croup or a partial upper airway obstruction. It's a high-pitched sound. That cough that they make, that croupy cough, some of them make when they're small, that is a form of stridor that you hear. And it's formed by your swelling. A lot of times it's irritated vocal cords that cause that. Bubbling, gurgling in the airway, that's usually because it's having to, if you hear bubbles, you got to have water or fluid. So think about that. Stridor, you don't have to have water or fluid. Usually you don't. But bubbling, gurgling, think of water, fluid, something is in there that's blocking these passages. And when you hear that, if they're unconscious, bubbling or gurgling, that's your indication to start suctioning. You don't have to wait till something's obvious, but if they're bubbling, gurgling, they have a limited level of consciousness, that's when you start suctioning this patient. Osculating, this picture here kind of helps that a little bit better, but you can see the midclavicular lines to where they're listening to the upper chest. And sometimes patient can have large pectoral muscles, large breasts, where that's not always possible right there. Maybe get closer to the collarbone if you can. But on those patients, you might have to actually start listening to where the pectoral muscle meets the chest on the sides, or the breast insertions on the side, or mid in the axillary regions itself. Sometimes you may have to do that to verify breath sounds are there. Midfield lung sounds, you see us, you want to try to listen around the breast itself, even on the back, under the scapulas. You want to go from side to side, and you want to go from up and down. You can't really listen to lung sounds through clothing. So if at all possible, well, you need to listen to lung sounds when the stethoscope is applied firmly to the skin. And remember, any type of obstruction or anything between that, especially the better scope that you got, the better stethoscope you have, any type of clothing like that, you could pick up the rubbing on there and give you a false interpretation or something. And what you're looking for here is you want to be able to identify normal breath sounds and what we call adventitious breath sounds, which is things that are abnormal or outside the norm. What is a normal breath sound? Pretty much quietness, just to tell that you got some air movement. Any other noise you hear in there is something to take note of, and what we call adventitious breath sounds. Now, with the normal breath sounds, listen to yourself. and or listen to somebody else like that. They pretty much quiet. You shouldn't really have to hear a whole lot. Uh, but you should be able to hear like the air movement. For example, when it goes into the bronchi, and then talk about bronchovascular. That's the little alveolaries, alveoli. Hold on, just alveoli, and uh, and then just above that, you got the bronchioles, real small bronchial tubes that feed those very distant uh, lung tracts. Now, when we hear wheezing, it's a lower airway obstruction in the bronchial tubes, and that's usually because it is narrowing. A lot of times you hear it on expiration. Sometimes you can hear it on inspiration and expiration, but that is some people have described it as a musical sound because it can sound different in different parts of the lung field, and based on where it is. You may have it on both sides, one side, or just in a local area. And what that signifies is there is some type of obstruction or a narrowed airway in that area. Now, crackles, that is a small noise. They used to define this as rails or raws, depending on where you came from, but they've kind of gotten away from the word rails to crackles. And it's kind of the way I used to remember this one. If you think of a fish aquarium, filter or bubble, those bubbling sounds like that, the fine ones, the real fine bubbles, that is kind of that crackling sound. When you get to rhonchi, these sounds are a little bit more pronounced. It's still a bubbling type noise, rattling almost. And these are bigger sounds because they're higher up into the bronchi of the lung system. They also, a lot of times, will clear with cough. A lot of times I've documented that this patient had bronchi both sides, however, cleared with cough, but would return. Now, that's probably due to secretions, some fluid that keeps coming in and out. They can get to sometime with pneumonia, asthma, bronchitis, some other things like that, where they get those bronchi noises in there. Now, I talked about stridor. It's a high-pitched sound. Mainly, you hear it like croup or things like that. Now, pleural friction rubs. You may not know what you're listening to initially, but for the most part, someone that has like sharp chest pain, a pleuritic type chest pain, they may say, "Well, I've had pleurisy in the past, and it feels like that again," or but it's usually local. It's usually in one area, and that's what's happening there. It's a grating type sound where between the parietal pleura and the visceral pleura, you have that lubrication that's there. But when you have these areas of it's not lubricated as much, it is inflamed, or you've got the inflammation going on, and those areas may rub together, and it will cause a grating type sound. It can be high pitch, low pitch, but it actually sometimes even sounds like a knocking sound, and it's usually painful in the area that this happens at. It can also happen in patients that are bedridden, that doesn't move around a lot, and aren't able to cough or sigh like they're supposed to, and they get these areas of atelectasis where they can have those pleural friction rubs. Now, there's a patient who coughs up like thick yellow or green sputum from the lungs. When it gets to that color, they probably got a pretty advanced respiratory infection, and you may have decreased airway sounds in one area or another, but sometimes it may even be localized. And you can have pneumonia in an upper lobe or lower lobes. That's why it's important to go from side to side and then up and down. And if you hear an area of getting breath sounds, and then there's this area to where there's not anything, then that may be some type of a pneumonia or something causing air not to get to that area. If they got a fever, it makes it easy to kind of determine what's going on. However, not everybody with pneumonia gets fevers. So there again, respiratory calls are one of the toughest for me, because sometimes you can't really tell which way to go with it initially, and more on respiratory emergencies later. But if respiratory system sounds confusing or challenging, it is. It's very challenging. To me, it's one of the toughest calls you can get is a respiratory call. A chest injury patient, they could cough up blood. It could be frothy white or pink sputum, and that's because the blood is mixing with air, blood fluid mixing with air. When you see pink sputum coming from the lungs and it's bubbly and frothy, there's a major issue going on, and it's uh, those can get bad for you. Now, the how deep a person breathes, for the most part, people may only breathe in and out for, let's say, an adult, large adult, probably are only going to breathe in around 600 cc's of air in and out, their tidal volume. So the amount of air that exchange back and forth depends on the rate and the tidal volume. So that would go like if you wanted to figure a minute volume later, if you actually knew that. If someone was putting out 500 cc's of air per ventilation times a minute, that would give you how much air is moving in a minute. But the shallow respirations means that they're not getting the amount of air that they need in a breath, so they're having to breathe fast to make up for it. So, and sometimes people start to have deep respirations. And why are they doing that? It may be sometimes they just may be awake, alert, and they're short of breath, trying to get more air in. But sometimes if they're not as responsive, they don't have that much control over their breathing. They may be breathing deep because they have a metabolic issue. They have a lot of CO2 or the pH is low, and they're trying to blow off all of the excess acid. So irregular respiratory rates mean there's a problem. And I gave an example a while back of this lady that was breathing 33 times a minute. That's all that was going on with her. And couldn't find a thing else. She was not complaining of shortness of breath, but her body was telling on her. And she was breathing 33 times a minute. And she ended up dying after we got to the hospital. So don't discount changes in respiratory rate. Now, one of my favorites is the cardiac system, cardiovascular system. It's when a chief complaint is associated with chest pain, discomfort, you want to check for abnormalities in the thoracic region. Back, and that also includes the back when you're talking about the upper torso. Anything that can do with the heart, lungs, you want to check that thoracic region. First you want to you want to listen to breath sounds. Look for trauma to the chest. Consider the pulse and respiratory rate, blood pressure, because sometimes with heavy or deep respirations, that pulse rate may change every time they take a breath in or out. It's called paroxysmal respiratory rate, and that's happened. That has to do with the intrathoracic pressure with these deep breaths. The rate and quality, rhythm of the pulse, you want to make sure it is noted as strong, whether it's regular, and the fact that you have one that's in the right range. Now, when we look at heart rate, the 60 to 100 is considered normal heart rate. Now, you're going to have some athletes that probably have a slower heart rate, but that still would be considered like a bradycardic rhythm. But you would want to document, hey, this patient, his chronic heart rate is in the 50s, just so that note that, but it's still considered a bradycardia. Maybe a therapeutic bradycardia. But pulse rate 60 to 100 is considered normal. Anything over 100 is considered to be tachycardia, and anything below 60 is considered to be bradycardia. Now, there again, if someone is sitting up talking to you, alert and oriented, their blood pressure is good, and they got a heart rate of 50, I wouldn't mess with it. But if that same person is, they have an altered LOC or low blood pressure and a heart rate less than 60, then that's probably going to need some intervention, because what they're doing, they're trying to compensate, but it's not working anymore once the vital signs start to get involved. Pulse quality. Initially, here's the way you want to term it. It's either strong, bounding, weak, or thready. If the pulse is normal, if you can detect a normal type pulse, you're going to want to note that as being strong. If it feels to be stronger than a normal pulse, we'll call it bounding, and those are correct descriptions, are in most top medical charts. And if it's difficult to feel, or you can barely feel it, we're going to call it weak or thready. Weak's probably a more better term that's associated with now. We used to use thready a lot, but you don't hear that a whole lot more. And the rhythm, is it fast or is it slow? Is it regular or irregular? Sometimes people that have an irregular pulse, ask them, hey, have you ever been told you have an irregular heartbeat? So I'm gonna say yes, I have AFib or I have PVCs, I have this going on. But if they say no, then you want to note that you probably when you do tell them that, they're probably going to get nervous about it. So you want to be kind of careful. Don't want to alarm them too much. But that note that if that's regular or not, how how fast is the pulse? Is there a pause in between each one that seems kind of normal, or sometimes you may have an extra pause, and when the pulse rate will begin again, it catches up. What you're looking at then is sometimes they may be having PVCs or premature ventricular contractions, and you'll feel a heartbeat, and you'll feel a pause. It's kind of a long pause, and then it'll start again. And that's simply something we'll look at in cardiology later, but that's what they call a compensatory pause. Is when the body will throw a PVC and then it kind of resets and they'll have an extra pause there for it. Now, if remember, the advanced EMTs don't carry a lot of cardiac drugs or advanced cardiac monitoring. This may be one to where if you got a long transport, depending on protocols, whether you want to call for paramedic backup or uh, they may tell you to continue on to a center with definitive care. But just be advised, if you start having cardiac problems, heart rhythm problems, uh, the paramedics have drugs that they may be able to do with that, to whereas an advanced EMT may not. So, we've talked a lot about blood pressure. There's reasons the blood pressure can fall, and it's usually due to it's got a pump problem, loss of vascular fluids, or the vascular tone or the vascular system has been interrupted. Some other things you might have an issue with is are they taking perhaps too much medication? They may have taken too much of a blood pressure medication. I've seen where one family member would give an elderly person their blood pressure medicine, the other one not know that it's been done, and give them another one, and it keeps their blood pressure low. A lot of time I've seen where they wouldn't even be able to talk when you set them up. You lay them down, they could talk to you. So the beta blocker overdose or antihypertensive medication, even if they may have changed medicines or upped the dose on it, and this may occur. So be alert of that may be the problem, and you'd get that in a good history. So the systolic pressure, contraction of the ventricles when it's pumping against the arteries. Diastolic is when it's at rest. That's considered that's the pump being primed. And there earlier it's outside of this, but if you got a high blood systolic, say 140, and your diastolic is 40, you probably got a valve issue that's probably not going to be corrected in the field. So because it's losing its prime every time, and they may have be in and out of consciousness, or if you set up they can't communicate, or they may have a real hard time breathing, and that's probably because if that aortic valve is not shutting, then the coronary arteries are not being perfused. That's a possibility, but like I said, we're not going to know that away. It was just something to suspect. Uh, don't take blood pressures in things like if the arm has an IV in it, or central line, or a port in that area. You really don't want to take a blood pressure in that arm if all possible. Over a dialysis fistula or shunt, or if they've had a mastectomy on that side, or if the injury's on that side, we don't want to take a blood pressure in that extremity if at all possible. And we can't emphasize enough about getting the proper size blood pressure cuff on a person. If it's not the right size cuff, your reading cannot be trusted. It's something that can't be reliable or something you're going to go on. So you need to get it close to the body. It needs to be the right size. It needs to grab the Velcro enough to where it gets a good hold. If it starts popping loose or not holding when you air it up, then they're probably going to need a smaller cuff, or a larger cuff for that. Now, some places by law have to carry like 3 to 4 sizes of a BP cuff. I know with all the electronic ones, I know we've got even a neonate, infant, and go up from there. So they need to have the right size cuff on, and it needs to be applied at the right place. If it's a thigh cuff it's probably not going to read good on the arm. Although there are those patients that have arms big enough to where it requires a thigh cuff. So there again, your blood pressure might be the best you can do or with what's available to you, but your blood pressure at that point may not be accurate. So just bear that in mind. Now we have sometimes you can do what we call a palpated blood pressure to where if you're in a hurry, or sometimes you might not can hear the bottom number, or might not be in a place where you can hear, and that's only measuring the systolic. So if you got a good systolic palpation, sometimes that's all you can do. So we got to make bets with what's available to us. A couple of terms you should be familiar with: hypotension and hypertension. Should be familiar with that from your medical terminology. Neurological assessment. Now, when we get into the trauma and the neuro section, I'll have some extra videos and things like that for you, but evaluating the neurological system is we got a few simple ways we can do it, which is what's presented to us. But I see a lot of people try to break it down so much to work to the point that they can get themselves in trouble. Now, first thing we want to do, this can happen when you walk in a room. You want to evaluate their level of consciousness. How are they communicating with you? Are they able to answer questions that you ask them? Are they answering it right? Or are they having to, if they start looking for somebody else for answers, that's a sign right there that they're being hesitant, whether or not they can help it or not. And remember the AVPU. That's what we want that's just a good baseline to help you judge something later or to describe it to the physician and people that take over care. You know, when I walk into the room, they're awake. Well, they wasn't awake, but when I called their name, they looked at me. Or I actually had to stimulate them painfully to make them wake up, or they didn't respond at all. So you need to get that good baseline, and that's done immediately when you walk in. You can do that simultaneously as you're looking at breathing and airway as well. So, you know, how deep does this get? Like I said, it's hard. You want to find yourself getting very deep into things, and that's when you need to fall back on your training, because you don't want to get tunnel vision or make a pre-concluded decision. You know, what's their activity level like right now? Are they moving around? Are they just responding to voice or sight? What's going on? What are they actually doing at that now? And if they're awake and able to talk, what is their mood, thought content like? Are they making sense? Are they giving appropriate words? If you ask them, hey, what is your name? And they tell you an orange ball, there's simply a problem here with the appropriate level of response that you're getting. You know, the facial expressions. Is it symmetrical? Are they having drooping on either side? Are they look like they're in pain, or they look kind of despondent? What does that tell you? Are they anxious, restlessness? Any of that? Is any of that going on? Do they look to be uncomfortable? They look like they want to tell you something, but they can't. Are you able to understand what they say? If it's something chronic, maybe a family member, somebody can help you with that. But are you actually able to understand what this patient's telling you or not? So, and then if they can't tell you all this, or you have to, if you suspect head trauma, inspect the head for it. You want to look for bruisings, deformity, anything like that, where blood may be coming from, skin changes. You want to repeat the LOC, level of consciousness or neurological assessment, in case there's any changes. Now, if it's normal, of course, you want to watch in case that it changes. But there again, if it's abnormal, you want to look and see if they start to improve or if they get worse. When you look at the pupils, they're supposed to be round and equal. They're supposed to constrict when they see a light. That's the simple part of it. Now, when you start seeing pupils that are abnormal or different from one side or the other, you got to start thinking, it's like, well, if they both dilate, that's something happening both sides. That could be something from like a drug overdose, hypoxia, something that is affecting it, you know, globally and uniformly. Now, if you start to see pupils that are unequal, the pupils require a steady flow of motor neurons to keep them dilated. I'm sorry, yeah, to keep them constricted, in other words, or to keep that pupillary dilation controlled. Your body should be able to immediately constrict the pupils or let them dilate in absence of light. But if one of them is unequal, what's happening is usually some type of brain swelling, whether it be from a bleed or trauma or cerebral edema, and it's compacting the optic nerve. The optic nerve runs between the cerebellum and the cerebrum. And if there's any type of swelling in there, it's going to compress on that nerve. The eye is going to stop receiving impulses to tell it to behave itself and maintain the proper diameter. And then it's going to dilate because it's simply not receiving those motor impulses anymore, neurological impulses, to act right. So that's when you might start seeing some unequal pupil size. Like in the middle, the top one, you got constricted pupils. Constricted pupils are usually due to a light response and opiate activity. In the middle, you got dilation. That could be something to a stimulant. It could be due to they may have had eye drops put in that makes their eyes do that, or it could be that they're exposed to the darkness. Or if you got fixed and dilated and they're not moving, they're not breathing, that could be a sign of death, because what's happening there is those motor neurons are not getting into the pupil anymore to tell them to behave. At the bottom, then you've got unequal pupils. What's the scenario here? Is it unequal and they're awake, alert, and talking to you? They may have something going on that just hadn't appeared to them yet. Sometimes you may see that in a person that has a cerebral bleed, but yet they haven't shown any other signs yet, but that edema is starting to go on, and that's why it's affecting first, is that cranial nerve going from the occipital region to the eyeball. So you got to feel and touch to make sure you're not missing out on any deformities, contusions, or depressions. When you feel the scalp, the head, you want to feel for symmetry and subcutaneous emphysema. It can show up in the neck, behind the ears. I remember one incident where this kid held his nose and he sneezed real bad, and it actually fractured a vocal cord, and he started to develop some subcutaneous emphysema in his neck. So you want to look for those contusions and things like that, especially. It's embarrassing to get to the ER, and it also shows that you probably missed something, that if you get there and they feel, oh, I got a big skull fracture back here in the back of the head. So always put your hands on areas and be able to answer questions. Now, you can't always, sometimes you've got to have rapport and trust somebody. Like if I get on the scene, like when I used to fly and I had a patient that was already perfectly packaged by an on-scene crew, and I'll ask them, hey, is anything to the head and the back? And I want to be able to trust them that they can tell me that with accuracy, because they were able to see the back of the head, the neck, before they rolled the patient, and be able to pass that on to me. So that's very important, to be able to find those and be confident when you pass it. Say, hey guys, we've already boarded him, but here's what I saw on the back. He's got bruising under the left scapula. I didn't feel any crepitus or deformity, but it seemed like it was very tender there. He did respond when I touched it. Breath sounds are good over that area. And that shows that you did a good inspection of that. And if there's any changes, then they know it could have occurred after the event, or it could have just got worse. Because the eyes, we talked about that, but you want to look at the color of the sclera, the white part of the eye. You look for yellowing, redness, anything like that. Foreign objects, of course. Look underneath the eyes, behind the ears. Now, the coon's eyes, under the eye, coon's eyes, and the battle scars, which are behind the ears, sometimes they develop over a period of time, but I have seen them to where they developed pretty quickly after a severe wreck. I picked up a girl once with severe facial trauma, and it literally looked like, at first I thought she had took makeup as a joke and put under her eyes down to almost the bottom of her cheeks, and it was coon's eyes that happened that fast. That's usually for these orbital or basilar skull fractures and stuff. So they can, if you see them pretty immediate, then that's some very significant injury that's going on. If they develop over time, they could say, like, note that hey, they didn't have this there. That you want to look for it, see if it's there or not, and make a note either way. But sometimes those develop a little bit later on, because most of the time it's a venous blood and it doesn't happen right away. Look in the mouth, ears, nose for fluids that may be draining out. Sometimes it's hard to tell what it is, if it's mixed with blood or anything. And I'm sure some of you may have heard of the halo sign, to where if it's dripping out of the ear and even the nose, that you can let it drip on that 4x4, and it will make the sign of a halo if there's any type of CSF in it. Now, and you want to be able to look for those fluids and mark for changes of it. Odors, was talking about smell on the breath. They got a fruity odor on the breath, could be indicative of high glucose level or some types of other ingestions, some types of drugs or chemicals. They may be inhaling that out as well. Some people just have real bad breath. When you look at the neck, first thing you want to make sure is, hey, I want to look for things that are not right. Let's say their trachea is midline. There's no JVD. I don't feel any bubbles or anything like that, or subcutaneous emphysema under the skin. Or you also want to look for jugular vein distension. That's things you want to see right away and make note of. Some of them may not develop right away. If you get there and they do have that going on initially, then they've got a pretty significant injury. When you look at the chest, look at it first without touching it. And then the first thing I want to do is a lot of times I'll probably listen first, because if I put my hands on it and they're cold or whatever, it may cause some a different reaction in the way they respond to me from there on. So I want to look, visualize, palpate over the chest area. I want to listen for lung sounds. I'm looking for the retractions. It could be anywhere between the ribs, the collarbones, up in that area. I want to I'll take my hand sometime and put on either side of the ribs as far back as I can get behind the scapula. Tell them to take a deep breath, and then another one, then another one. I'll do that about as I'm moving my hands forward, and I'm feeling for crepitus, any type of abnormalities or anything like that. Now, sometimes you may have a paradoxical motion associated with fractured ribs or flailed chest, and it doesn't necessarily, used to they used to say, hey, if they've got 3 or more ribs broken, 2 or more places, it creates that. Well, now they're saying anytime there's an unstable chest wall, you've got that paradoxical motion. So, and when that's happening, the ribs and the rib cage are not able to make a compliant container for the air to go into or to be maintained. So you're probably going to have some issues with that. Now, I'll show you later some kind of stabilizing treatments for that, but you want to look to that paradoxical motion and note where that's at and see if it changes any. There also may be some crepitus that you hear in those areas. Now, crepitus for a rib cage, that's pretty significant. I mean, a lot of times when you break ribs, they break, but they stay pretty much in the same area and they don't move a lot back and forth. So if you hear crepitus with ribs, that patient, if they're not unconscious, they're going to be in a lot of severe pain and possibly have some swelling around that because of those blood vessels that go over under the bottom of those ribs. In the subcutaneous emphysema, now I've seen it where sometimes it'll develop in areas of the chest. I've seen it develop so bad in females that you couldn't even really tell that they had breasts anymore. It just kind of puffed up all around there, and it is firm. So even if you can't tell if it's air or just a large inflammation, go ahead and lean toward the worst part of it, of what it could be, and note that. So, and then, but another thing is with a lot of edema, you still may have adequate breath sounds, whereas if it's subacute air, you may not have. You may have decreased breath sounds in that area. The abdomen, you want to listen to an abdomen before you touch it, because a lot of times once you press or stimulate or palpate that smooth muscle in the intestines, it may shut down for a little bit. Also, if they're very tender over that region, and if you lay the stethoscope on there lightly, you might be able to hear if there's bowel sounds or not. A lot of time after significant blunt trauma to the abdomen, the patient does not have any bowel sounds under that area anymore. So after you listen, then you might want to palpate and see if there's any tenderness, rigidity, or is there a guarding. Now, you don't want to be real hard about it. I mean, if you touch one area of the abdomen and it hurts, there's no sense in pushing that to the back of their body to try to elucidate, see if it gets any worse. There's not. What you do want to note that is, like, sometimes you can press in and it doesn't hurt, but when you let go, it hurts. Like a lot of times you'll see that with an appendicitis. So, is their abdomen rigid, or are they having guarding? A lot of times when blood is not in the place that it's supposed to be, it hurts. And internal bleeding many times can be determined or suspected if they got a rigid abdomen. And what's happening there is that blood may be entering inside the abdominal cavity, and it stimulates the nerves inside there, and it makes the muscles real rigid. It's kind of a natural type of guarding. It makes the muscles rigid to where they're protecting any other type of injury that may be in there. Also, uh, loose blood in the abdomen can cause other areas to hurt. If it goes up like to the diaphragm, they may have severe shoulder pain on either side because it's irritating the phrenic nerve of the diaphragm, which radiates to the shoulder. Sometimes I've seen that in ectopic pregnancies to where they hurt real bad in their belly, they're tender, and they couldn't even lay flat because their shoulders hurt them so bad. And that's because that loose blood in there was irritating those nerves. What I have seen in that case is that they were so hypotensive you couldn't really lay them, you couldn't sit them up. But when you laid them flat, they were in such intense pain. So that's a challenge there. Uh, so I mean, just think about anytime you got bruising or subjective trauma and they got severe shoulder pain or radiating like that, you got to think they've probably got some bleeding on the inside there. So blood bruising over an area, you got to think about, hopefully that's superficial or bruising or damage to just the external tissue outside of the abdominal cavity between the skin and the muscle wall. But if it's coming from the inside, bruising immediately at the scene, that can be very, very bad because it takes significant to get through all those layers, significant amount of bleeding to get through those layers. I saw a girl seatbelt. She was 6 months pregnant, and as soon as I got there, she was bruised from hip to hip, pretty bad. And we get her to the hospital, and it turned out the baby had been killed. But the force had tore everything loose on the inside. She lived, but the baby it must have died instantly. So when you see that bleeding or bruising on the abdomen on the outside immediately, that is a significant injury. The abdomen, you got a lot of stuff in there. It's difficult to tell or pinpoint where an injury is because of all the referred pain. So anytime there's any type of asymmetry or it's off balance or just simply look like, it could be because the organ is swollen. Usually around every organ, they got a membrane. If it fills with blood, it's going to swell up, and it could be accumulating in that. Severe distension can be the sign of it could be from blood if there's trauma initiated, or it could be from ascites as far as infection of the liver, like cirrhosis of that matter, or sometimes what they call like a leaky gut syndrome, or fluids are just simply permeating to that third space and causing it to swell up then, or even infection, sepsis inside that peritoneal space could cause the abdomen to be distended. Remember, you got your 4 quadrants. Remember your anatomy, earlier pictures of what is in those quadrants. You need to have a good idea of what's in each quadrant and be able to describe where they're hurting at. Patient is complaining of pain in the right lower abdomen. He has pain radiating to the left lower abdomen. Just things like that. You want to be able to describe where that's at and what organs are in there. So, and the pressure that I was trying to get you to remember earlier was like if you press in on the abdomen and nothing happens, you release on it. That's going to be rebound tenderness, and that is significant whether or not it hurts continuous or when you push in and then when it comes out. The pelvis, there again, you don't have to use a lot of force on this because pelvic injuries can be painful enough. And you simply want to see if there's a change when you press in, press back. You want to check the symphysis pubis bone, which is right above the genitalia. Just palpate that, put light pressure to see if there's any change or crepitus movement or anything like that with it. Also, inside the pelvis, man, you got some major vessels in there, and a pelvic fracture, they automatically lose probably about a liter, and that's pretty much minimal what they may be losing inside their pelvic cavity with a pelvic type fracture. So that's usually a trauma exam. Usually the medical patients, there's really not a reason if they didn't have any trauma to suspect pelvic instability or anything like that. So it's usually not done in medical emergencies, but hey, if you can say why I did it, well, here's why. I mean, just be able to say why. Now, female patients, sometimes you have to check if they're having severe bleeding, whether, where's this coming from? Is this vaginal? Is it urethra open? Is it coming from the urinary tract, rectum? Where is this coming from? Because I had a patient wants that she sat down on a glass, and it literally gave her an episiotomy. It cut her from her vagina all the way through to her rectum. And of course, we had to examine to see where everything was coming from. Let me tell you what, that's a lot of bleeding, a lot of bleeding. It took a lot of packing and to keep her from actually bleeding to death. You can't put a tourniquet or anything on like that. So we end up giving her some TXA, some pain medicine, and of course direct pressure, and we got her to the hospital. So she had to have surgical intervention. But sometimes you got to be able to examine to find out where these injuries are from, give a heads up, and know what you're dealing with. And as far as males, bleeding from that area, is it coming from the penis or is it coming from the rectum? So that needs to be noted as well. Try to find out where it's coming from. Extremities, DCAT, BTLS, we talked about that a couple of nights ago, but you want to check for motor function. Whether it's, hey, can you move your feet up and down? Can you feel me touching you? And you need to note, hey, motor sensory function is normal per patient. Hey, do they tell you there's no change in that? Or if they do have a change, be able to describe that. I always make people do like the gas pedal thing up and down with their feet, maybe lift their feet, their legs if they can, squeeze my hands, and that's just simply ruling out any kind of problems. And if like I had a lady the other night, she was telling me that she felt normal when I checked her the first time, and I noted as such, patient denied any change in motor sensory function. However, when we got to the hospital, she stated that her right arm was starting to have some numbness. However, the motor part was not affected. So you want to be able to note those. You don't want to go through the whole thing and say, well, I checked that and everything was fine, and then something else is discovered later. So be sure you check those areas and compare them. You want to have I like to put down the way I found them and the way I left them. So when you're looking at the extremities also, you're looking for edema in the legs, pitting edema. That's when like you press your thumb in or your finger in and that dent stays in the swollen region. So you want to make sure that you note whether that's happening or not. And what we're looking for edema, like if they're having chest pain or shortness of breath, you want to check the feet and the ankles to see if they have any edema there, because that may be a sign of heart failure. So you want to note that as well. You want to check capillary refill. You want to check sensation in there. And I like to note that I'll put like distal sensation, pulses were positive in the extremities, present and positive, which means that, it's there. I checked it, I noted it, and it was there appropriately. Now, the back part, when we roll them up, we want to look at the back. You might not have to, and if you suspect trauma to the head, neck, you don't wait till you get to the secondary to do the back. Go ahead and look at it. Treat it as part of the chest if you suspect thoracic trauma, or if they're unconscious. You want to look at that back. You want to find out what's causing that, because you want to look at that and find it before they go on a backboard or on the stretcher. So you want to look at it, you want to feel it, see if there's any type of abnormalities, feel if anything might be penetrating there. You want to rub put your hands like underneath people and look at them to see if there's any blood coming from anywhere. So, and when you do this, be sure you keep the spine in line at all times. This is if this patient cannot tell you anything and are unconscious. So you want to keep that in line, not to cause any further damage. But note, look at the back. So much is missed by people not looking at it exactly. So, if time permits, now you might have a long enough transport to where you might do a more focused exam. It may not be indicated. It simply may not be indicated. So, what would you expect to find if you did a further exam, or how will this change, or how will this change your treatment choices? Would it make a change on them? Is there, like I said, does it really need to do anything else? So then once you do this head to toe or this secondary exam, you might find other injuries that could possibly be life-threatening. Of course, you'd want to deal with them. And there again, anytime you run across a problem inside of while you're doing a physical exam, you may have to stop, reevaluate, back up, and start over again, or correct that problem as you find it. And sometimes during these transports, you may find a problem that makes you decide to go to a different facility. For example, one may not have vascular surgery on hand like that. You may start off and don't find a lot initially, and you're headed to a general hospital, and you find out when you're checking the abdomen, hey, it's very tender. It wasn't there initially, but now they're starting to have some distension. That may come into play as far as you saying, well, you know what, we may need to go somewhere now that has surgery, because that might be what's going on with them. Now, throughout the process, there again, don't be the guy that shows up at the hospital and your patient died somewhere along the way because you were busy doing your report. But continually reassess your ABCDEs, make sure nothing has changed. You want to have, as far as vital signs, you need to have vital signs every, as far as critical patients, every 5 minutes, or as soon as you can, like that, because you want to check those trends. People that are not critical, you can make it spread it out to 10, 15 minutes. But also, the biggest thing you can keep an eye on is their LOC with your baseline assessment. How does this change? When you start doing your IV therapy and things like that, you may have a low blood pressure, and you give let's say you give a half a liter bolus, and the blood pressure comes up. Don't let that fool you that to where everything is okay and you don't have to get involved anymore. That can very well be just transit because of the fluid, because of the increase in fluid. But then again, it may drift away again. So, like as far as trends go, if you give a bolus, check a blood pressure, check it again, check it. That's why we do it every 5 minutes. If they're requiring a bolus, then that's a critical patient. They need to be monitored more often. Sometimes people's chief complaint can change. So you want to get the initial, and sometimes, like I said, it may change in route. Is what you're doing, is it making them better? Is their problem getting worse? Has it gotten better despite what you've done? And was there anything else indicated? Now, there's been times to where people may have diminished breath sounds, like having an asthma attack, and you give them a bronchial dilator. And after you dilate the bronchioles to where air can move more in and out, then you start hearing maybe rales and rhonchi, because now it takes more air to make those noises. And if you do the bronchial dilator and it opens them up more, just expect you might hear different sounds in there. And it's because now more air is getting in, and this patient might not only be having asthma, but they may have some bronchitis and stuff going along with it. So reassess after every treatment, reassess to see if anything changed for the better or for the worse. And it's also important to document that. You document your treatment and how they responded. Many times it's easy to get lost or distracted in a patient assessment. So that's when I say you need to get your own system down that covers this, that covers all of the bases, and not get distracted. There is such thing called a distracting injury. Sometimes it can be like, let's say if the patient has an amputated forearm, and you get that bleeding controlled, it can really distract of what else might be happening to that person. You look at just retract this, let's say the forearm's amputated between the elbow and the wrist, and you're dealing with that. And you know what? On the other side, he may have a gunshot wound that was just that you got tunnel vision on one side and got distracted by that real significant injury that you missed something else. So just bear in mind that there could be other things going on as well. Reassessment, unstable every 5, reassess stable patients every 15 minutes, but at least have 2 sets in there. If it's a 15-minute ride to the hospital, then if it's unstable and they're stable, you want to have 2 sets of vitals, when you pick them up and when you drop them off. So we did most of it a couple nights ago, and this is pretty much all of them for tonight. It is a Saturday night, so we are finishing up early. Any comments, questions, concerns about tonight's lesson? All right, we'll be back on let me pull that one up. Let me look at the schedule right quick. Let me see where to go. Well, it looks like we start on airway on Monday the 1st. So I'll see y'all back Monday the 1st. The code for tonight will be, let's see, 130715. 130715. All right, everybody. Y'all have a good rest of the week, and I'll catch y'all on Monday night. Mm.